Chapter 24, Urinary Anatomy, Screencast 4. Now, this final screencast will focus on the remaining structures of the urinary system, and that will be the ureters, the urinary bladder, and the urethra. Together, this is known as the urinary tract. And the ureters, there are these long epithelial-lined fibromuscular tubes, and their role is to conduct urine from the kidneys to the urinary bladder. Same as the kidneys, they are in a retroperitoneal position. They are originating from the renal pelvis as it exits the hilum of the kidney. And they basically will enter the posterolateral wall at the base of the urinary bladder. Now, moving forward, there are a couple of terms that I'm going to put a real emphasis on because they're layers that are associated with tubes that are not vessels. The first that we're going to encounter is the mucosa. And the mucosa is actually formed by this transitional epithelium and external lamina propria. So keep in mind, when you went through histology in A&P 1, probably you went over transitional epithelium. And remember, it has some interesting properties. It has the ability to expand. So this is a great place to find this tissue because the ureter needs to be able to expand to hold the urine. When there's no urine present, they actually fold and create these folds that are mucosal folds. Now, another important layer is going to be the muscularis. It has an inner longitudinal and outer circular layer of smooth muscle cells. So remember, this is smooth muscle and is under autonomic control. And basically, these muscles will contract in a coordinated rhythmic way once urine is present. And the role here is actually to move urine through the ureters into the bladder. The last and outermost layer is going to be the external layer of the ureter wall. And this is made up of collagen and elastic fibers and areolar connective tissue. Now, the ureters basically project in an oblique angle through the bladder, and they're going to be compressed as the bladder distends and becomes full with urine. What this does, basically, this pressure, it's going to decrease the likelihood of urine backflowing during urination. The ureters are actually innervated by the autonomic nervous system. Primarily, we're looking at sympathetic axons and also parasympathetic. And quite often, pain in these dermatomes is quite often referred to as loin to groin. Here, one of the things I want to point out is that characteristic of the mucosa, and I put a lot of emphasis on the mucosa because that is the layer that is actually in contact with whatever happens to be in the tube. And so keep in mind, there are mucosal adaptations based upon what function is going to take place in this part of the tube. This will become especially apparent when we talk about the digestive system. We also have the muscularis here. So this is smooth muscle, and once again, under autonomic control. And there is both sympathetic and parasympathetic activity to the muscularis layer. And then there is an outermost layer, which is the adventitia. And keep in mind, that's mostly connective tissue overall. Now, the urinary bladder, this is an expandable muscular container. And we want to think of it as a storage or reservoir for urine. Bladder capacity is approximately a liter. It is positioned immediately posterior to the pubic symphysis. It is going to be antero-inferior to the uterus in females and anterior to the rectum and superior to the prostate gland in males. It also is considered to be retroperitoneal. The superior surface is covered with the parietal peritoneum. Now, quite often, the urinary bladder looks like an inverted pyramid when empty, but it changes shape as it fills with urine and becomes oval shaped. Now, the trigone, this is the posterior-inferior triangular area of the bladder wall, and it is formed by connecting imaginary lines that are connecting the openings of the ureters and the urethra. Now, this area will remain immobile as the bladder fills and empties. And what it actually does, it funnels to direct urine into the urethra during contraction of the bladder. This is one of the areas where you see lots of bladder infections in this part or inferior portion of the bladder. Now, here, when we look at the histology of the urinary bladder, we're going to encounter 4 tunics, not 3 tunics. Remember, we saw 3 tunics within the ureters. We now have 4 tunics. And the new layer is the submucosa. So we basically have the mucosa, the submucosa, the muscularis, and the adventitia. Now, once again, the mucosa is always the innermost layer, and that is going to be lining the lumen of the bladder. It also is made by transitional epithelium, as was the ureters. So this allows it to change shape and accommodates the distension that will take place as the bladder fills with urine. There is also this lamina propria that is supporting the mucosa. And once again, we're going to see mucosal folds that allow for a greater distension. The submucosa, this actually lies immediately external to the mucosa. Then we have the muscularis. Now here we actually have 3 layers of smooth muscle. Collectively, the muscular wall of the bladder is known as the detrusor muscle. They're also at the base of the bladder. A thickening of the detrusor muscle is the involuntary internal urethral sphincter, and it's formed by a smooth muscle encircling the urethral opening. Then the outermost area, once again, is the adventitia, and this is mostly just areolar connective tissue, and it will form a serosa, and we'll talk about that later when we start talking about membranes in the superior region. Here we basically see the bladder overall. And notice once again, I want to put an emphasis that the entire muscularis is known as the detrusor muscle. It's not just one part. So that entire layer, okay, we also can see the trigone. And remember, this is where the ureters come in. This is where the urethra. And then we basically have an imaginary line connecting those 3 dots, ending up with this triangular region. And it really does act as a funnel for the urine to move into the urethra. Here we also see the internal urethral sphincter at the base of the bladder. Now remember, this is going to encircle because the urethra is a tube exiting the bladder, and the internal urethral sphincter is under autonomic control. And then we have the external urethral sphincter. This is actually skeletal muscle, so this is under somatic or voluntary control. Now here, once again, we can see the histology of the bladder, and the main characteristic of the mucosa is going to be that transitional epithelial tissue that allows the bladder to actually expand. We can also see the mucosal folds, which will allow for a greater volume of urine to be held by the bladder itself. Now, the last structure of the urinary tract is the urethra, and this is actually an epithelial-lined fibromuscular tube. It exits the urinary bladder through the urethral opening, and basically the job is to move urine to the exterior of the body. There are 2 sphincters that are actually going to be involved that restrict the release of urine until bladder pressure is high enough. And those are known as the internal urethral sphincter. Remember, this is smooth muscle and under autonomic control. And then there is the external urethral sphincter, and that is under somatic or voluntary control. Now, the urethra, the internal urethral sphincter, once again, is made up of smooth muscle, and it surrounds the neck of the bladder, and it's going to be controlled by the autonomic nervous system. If we look at the external urethral sphincter, as we noted previously, it's inferior to the internal urethral sphincter. It is made up of skeletal muscle fibers of the pelvic diaphragm. So because it's skeletal muscle, it is under voluntary control, and that is the muscle that's learned to control during toilet training of a child. Now, there are significant differences between the male urethra versus the female urethra, and we're first going to be looking at the female urethra. One thing to remember here is the female urethra is single function, and that is to transport urine from the urinary bladder to the exterior. It has a lumen that's lined with transitional epithelium near the junction with the bladder. And then, for the most part, there's going to be this non-keratinized stratified squamous along most of its length. The opening is at the external urethral orifice found in the female perineum, whereas the male urethra is very different. It is a passageway for both urine and semen. It actually is subdivided into 3 segments. They are the prostatic urethra, the membranous urethra, and spongy urethra. Now, if we look at the prostatic urethra, that's the first part, and it extends through the prostate gland, and it is inferior to the male bladder. It is the most dilatable portion. There are a number of small prostatic ducts that enter the prostatic urethra. It also is going to be lined by transitional epithelial tissue, and there are going to be 2 smooth muscle bundles that are surrounding the mucosa. The membranous urethra, that is the shortest and least dilatable portion of the urethra. It's relatively short, extends from the inferior prostate gland. It's surrounded by skeletal muscle fibers forming the external urethral sphincter. Then we actually have the spongy urethra. It's also known as the penile urethra. This is the longest part of the male urethra. It's encased by a cylinder of erectile tissue within the penis known as the corpus spongiosum. We'll come back to this when we do the reproductive system. And so the spongy urethra extends to the external urethral orifice. Now here we can see some differences between the female urethra versus the male urethra. And here we can basically see that the female urethra is much shorter. And because of how short it is and its proximity and location, this is one of the primary reasons why we actually see more urinary tract infections in women than we do in men. Here we can actually see the male urethra. Notice it's much longer. Remember, the male urethra is double function, so both sexual and elimination of urine. We see the first part, the prostatic urethra, which is actually moving through the prostate. We have the membranous urethra. Remember, this helps form part of the external urethral sphincter. And then we have the largest part of the male urethra, which is the spongy urethra, also known as penile urethra. And remember, it is surrounded by a cylinder of erectile tissue. Now, the last thing that we want to address in this screencast are going to be kidney stones. And basically, they are formed from these crystalline materials that actually build up within the kidney. Now, there are a number of risk factors that increase the likelihood of developing kidney stones. One will be inadequate intake of fluid, and this causes reduced urinary flow. It could be an individual that is more prone to urinary tract infections, or there's actually some abnormal chemical or mineral levels found in the urine. Now, small stones are actually asymptomatic. Larger stones become obstructed within the kidney, the renal pelvis, and the ureter. This is where we actually see that loin to groin pain that is associated with kidney stones, and they must pass on their own if they're less than 4 millimeters. If they are larger than that, then they may actually require lithotripsy or uteroscopy, where they are actually broken up and can be passed in that particular manner.